Hello, everyone, and welcome to this session on discussing the most recent publication on the second international consensus guidelines on the management of BK nephropathies. I have with me Hans Hirsch and Camille Kotton. I am Stefan Tullius. I'm a transplant surgeon in Boston, and I'm the incoming editor-in-chief for transplantation and transplantation direct. Briefly, to introduce Camille. Camille is the clinical director for transplant and immunocompromised host infectious diseases at the Mass General. She is also the incoming secretary of the Transplantation Society and an associate professor at Harvard Medical School. Hans is a professor of medicine. He's the senior consultant in infectious diseases and head of the Division of Transplantation and Clinical Virology at the University of Basel as an AST fellow, and has been very much involved in guidelines together in producing and publishing guidelines together with Camille in the past. This guideline now has really been a Herculean effort that both of them have put together, and I think it is of great value for the entire transplant community to have guidelines in an area that is most relevant in transplantation and yet very challenging to deal with. So I want to start out by asking them both questions in regard to the publication of those guidelines and look forward to this conversation. Starting out with Camille. Camille, I'm interested in what in the preparation of this meeting has been the motivation to convene this international consensus meeting?
Yeah, that's a great question. So it had been the better part of 20 years since the original version of consensus guidelines on BK management. And we had accumulated a lot more information and knowledge, and we thought it was a good time to update the guidelines. We were able to get an completely independent grant from Roche in order to sponsor the guidelines. They were not involved in any way with organization and did not have any say in how guidelines evolved. And then I met with Hans, who is one of the international main experts on BK. He actually has written multiple versions of the American Society of Transplantation BK guidelines and is certainly very well known for his work in the field. And so together we brainstormed and put together a list of international experts. We really wanted to make sure that all regions of the world were well represented, and that includes high income, low income, geographically diverse, all kinds of different transplant management for a variety of reasons. And so we put that list together and invited people, and we had half a dozen different work groups with areas of specialization, and a lot of work was done before the meeting. And then we all got together for a hybrid meeting where we developed consensus and used grade as the way to clarify the recommendations and the level of evidence.
Yeah, and with a fantastic product that you put together with this entire group. Asking you, Camille, how did you select participants, stakeholders, patients' involvement, advocacy groups? How were they all represented to produce those guidelines?
Sure. Well, we primarily used our experience with the literature who had published significantly in the field, and then who were known to be key opinion leaders in the field. So this was primarily clinicians and researchers and other key stakeholders who were chosen to be involved in the development. For this type of document, many of us mentioned patient experiences and thought hard about patient representation.
Hans, turning it to you, BK nephropathy is extremely relevant in the way that we deal with patients in our field. What do you consider the most relevant risk factors of BK nephropathy?
Yeah, I think the starting point was that we wanted to see if there were actually differences in the different areas and the different patient um, exposures to the virus. And I think that's why the updated second international consensus guidelines are extremely valuable. Camille was already alluding to this, that we had different centers and different parts of the TTS regions to come in with their expertise. And then as it emerged, actually, that there are significantly higher rates for older recipients, for male recipients, and patients that receive grafts from donors that already have BK polyomavirus activated as detected by shedding the virus in the urine. And the use of the current standard immunosuppression for maintenance, like combinations of tacrolimus and mycophenolate, I think was very, very clear across all of these centers. And I think that was very much appreciated. So these risk factors were put together by a group of clinicians and also people involved in diagnostics, but then were cross-checked across the different TTS regions, and I think that's also very valuable. They were graded as with respect to the strength of the evidence. Of course, the risk factors could not make any recommendations with respect how to lower these risk factors, but I think there was quite a good consensus on identifying these risk factors. Many of these risk factors have been published individually or alone, and there was also a meta-analysis performed by one of the participants, Michael Eder, who was very, very much convincing by having a very good background. This data on the meta-analysis will come out on another occasion.
Yeah, I entirely agree. I think particularly the grading gives it much more granularity in understanding risk factors. Now, the center of the guidelines are recommendations. What are the recommendations in regard to diagnosis, Hans?
I think the very important is the regular screening of the patients, which is much denser as compared to the previous screening recommendations. And this would enable clinicians to evaluate the patient and allow for a reduction in immunosuppression using predefined protocols. So really, the combination of screening and acting, I think that is very much at the center of these guidelines. And of course, we need to make sure that there were not any specific individual risks. So one of the conclusions of these guidelines is to try, in the absence of specific antiviral interventions, to reduce the impact of BK nephropathy by proactive screening, by monitoring, clinically integrated histopathology evaluation, and the timely reduction of immunosuppression after careful consideration of individual risk. So one of the key issues was that for a standard risk patient, you don't need to do a biopsy unless there was evidence of failing function. I think this is a little bit a paradigm shift to what people thought previously, and which very much caused a delayed action and then also failure of this strategy.
Very true. I think the other piece on in regard to recommendations that is most relevant is therapy. Camille, what have been key findings and recommendations in regard to therapy?
Yes, well, therapy for BK is primarily reduction of immunosuppression, and we spent a lot of time discussing optimal methods for, as Hans was saying, screening and then responding to positive results. And we have a new flow diagram in the BK guidelines that is intended to be the kind of thing that you sort of rip out and stick on the wall in clinic and ponder, or at least metaphorically in the era of electronics. I don't know if people are still doing that. But you sort of work through the flow diagram and think about reduction of immunosuppression. And then honestly, over the past couple of decades, we've had a variety of suggested therapeutic options that haven't really panned out, things like leflunomide and ciprofloxacin, and cidofovir. And so we're basically saying we don't recommend standard use outside of clinical trials. And so I think that it's helpful to cut down on a lot of the noise and things that people were doing that can have untoward side effects. Leflunomide is immunosuppressive, and so it's not a zero risk. And cidofovir can be nephrotoxic. So we were worried about some of the therapies that were being used, and I think it really helps to have consensus guidelines suggesting what appropriate use is and then isn't. So we're hoping for clarity. I think the way that recommendations read is now quite clear. We've gotten a lot of positive feedback about that.
No, I entirely agree. I think that is really an aspect of the strengths of those guidelines. Now, one aspect that is always, I find, challenging to deal with are recommendations for patients who receive a retransplant subsequent to BK nephropathy. What are the recommendations there? What are the recommendations, including the discussion that we frequently then have, should they have those patients a transplant nephrectomy?
Yeah.
Yeah, I think this is a very important question, and we were fortunate to have a team, a working group, to specifically look at this question. And the recommendations are actually quite straightforward. So if the patient per se is eligible for retransplantation with all other parameters, and we have no evidence of BK-DNAemia, the detection of BK viral loads in the blood, then the idea is that obviously the patient's immune system is able to control the virus, and then you can actually proceed. There may be a slightly higher risk of having BK replication started again, but I think the way the literature reads right now is that this is losing a graft to BK nephropathy and having cleared virus replication. That is actually a good starting point for retransplantation. A little bit more difficult it is when we have persistent BK-DNAemia. And here various options come into play, but that's also where there's very limited evidence. And in these cases, especially when you are considering preemptive retransplantation and persisting DNAemia, then some experts would consider nephrectomy, which is not a simple surgical intervention, Stefan, as you know best of all of us here.
Maybe, Hans, a brief comment on experimental treatments in this area where we are frequently confronted with not being successful with the armamentarium of treatments we have. There is the desire to apply experimental treatments. What are your thoughts on that?
I think in principle, we should have the patients identified with increasing BK-DNAemia loads for a preemptive intervention. And in our experience and that of many centers, this works well in 80 to 90% of the patients if delivered on time. Now, the burned cases are much more difficult. And then obviously we want to resort to experimental rescue operations, but we cannot expect that they are working. I think anything is possible there, but not all of these measures will be successful. One of the key interventions that have been discussed very actively at the recent ATC 2024 in Philadelphia was the use of intravenous immunoglobulins. So there is a tremendous interest, and obviously in a difficult case, this would be one of the options that could be tried. I think also the guidelines are sort of accepting that this could be used. But in principle, we would love to see patients enrolled in randomized clinical trials. The BK virus field suffers from too much of a history of individualized management that could, in the end, not provide sufficient evidence in many, many cases. So experimental treatments best in randomized clinical trials. And of course, for the individual rescue operation, we might resort to other means, but they may not be successful.
And finally, to bring this topic to closure, Camille, there is obviously a significant knowledge gap that we have in the area. What would you define as the most pressing aspects that we need to be working on moving forward?
That's a great question. As the co-leader of half a dozen work groups, I think all the work groups thought that they had the most important areas to move forward. I think Hans's points about experimental treatments and the need for excellent randomized controlled trials can't be emphasized enough. In reviewing the level of evidence, there's really, it's really challenging to have single center studies, small numbers of patients, suggestions of usefulness of various therapies, but we really need to get together, organize. Hopefully these BK guidelines can serve as a platform for future studies, and then we can enhance our knowledge about, I would say, especially therapeutics, experimental therapeutics, but optimizing immunosuppression management. And I think now that we've sort of leveled the playing field and organized things, hopefully we could have better clinical trials looking at those things. I think at this point, our diagnostics are pretty good. Our understanding of epidemiology is relatively good. One of the challenges there is the lack of knowing who's at really high risk. It does look like there's some emerging diagnostic information on cell-mediated immunity. It would be good to have better serology. There's still a lot of work to be done. This is a relatively common infection for kidney transplant recipients. And we're really hoping that these guidelines will be both useful clinically, but for future research endeavors.
Entirely agree. Hans, any additional comments from your side?
No, I think part of the enthusiasm that was generated is really due to this very good interaction between Camille, myself, and all the other stakeholders. I think we felt this was not only among the working group leaders, but this was actually going in the individual groups and was very much evident at the on-site meeting, this hybrid meeting that we had in Basel in 2022. So maybe there are some low-hanging fruits which concern mostly laboratory assays. They don't hurt anybody except maybe the money part. With regard to thresholds, what is the best threshold? What is the role of serology in donor and recipient by analogy with CMV, high risk, D plus or minus? What's the role of cell-mediated immunity? And do we have better biomarkers? Can we develop them to distinguish BK nephropathy from, for example, T-cell mediated rejection? I think with respect to randomized controlled trials, even non-inferiority would be an important goal, let alone superiority for management options. We are lacking this. So in the guidelines, I think we defined a very fair starting point, how to reduce immunosuppression according to two different strategies. And we hope, of course, that in combination with maybe more promising, successful interventions, that really our new guidelines will be the perfect platform to move forward. So really thanks to Camille and to all the working group members that we could put this together on a global scale of expertise.
Yes, and Thanks, Hans. And I'd also really like to thank TTS. They provided all of the support for work group meetings until the time of the big meeting, all the organization. And then they did a wonderful job with the hybrid meeting, which, as we know, is not easy to do, but fabulous support for the meeting and afterwards. And we're just so appreciative that this wonderful international transplant organization would be so supportive and just overall wonderful with the guideline development. So we're very appreciative to TTS.
So maybe a last word, what are key obstacles? I think this is to talk to regulatory authorities to understand the complication of BK in a much better and a much more thorough way. And I think here a lot of work needs to be done to where really to push the envelope on the side of the North Atlantic left and right, east and west, to come to a reasonable biomarker. I think this is where a lot of obstacles is to randomized control trials, obstacles in this field. And I'd like to remind everybody of HIV/AIDS, where the acceptance of HIV loads as a surrogate of AIDS, a complication that is 5 to 10 years down the road, was finally accepted. I mean, we need to get all the evidence together and have regulators understand this disease much better. We hope that our guidelines will also help in this direction.
Thank you. Yeah, indeed, biomarkers, a big topic that we would need to talk about in different areas. Well, congratulations again. This is a fantastic work, fantastic publication on the International Consensus Guidelines for BK nephropathy that came out in Transplantation in April of this year. Really highly recommend to read this as it really allows to improve the way that we are treating patients with that condition. Thank you very much again, and have a wonderful day.
My pleasure. Thank you, Stefan. Thank you, Camille.
Thank you. Thanks a lot.